Thank you, Ramesh, and it's a pleasure to be part of the Golden Jubilee, sir. And I congratulate all of us for being part of the surgical gastro fraternity of Kerala. My topic is technical, not much of theory. It's about laparoscopic distal pancreatectomy. So we know that it is becoming the standard of care in benign and probably low-grade malignant lesions of the tail of body and tail of pancreas. It is proven to be less morbid and the recovery is better. Lung pulmonary complications are better, although there is no difference between the pancreatic fistula rate. So we have a complete distal splenopancreatectomy, or you can preserve the spleen if possible. It has been proven that it is better than removing the spleen. We have two techniques. It may be either a Warsaw technique, which was described earlier, or it may be a Kimura's technique where we preserve both the splenic artery and vein completely, remove the segment of the pancreas with bearing the tumor. So I would like to present two cases. One is this is a 46-year-old man with no other comorbidities who had a mild pancreatitis in May 2023. He was investigated extensively but could not find any specific cause. He had a recurrence 1 month later, I think 5 weeks later, and a repeat CT scan was done which showed an ill-defined mass in the body of the pancreas. EUS was done and FNA showed atypical cells suspicious of malignancy. So this is the CT scan of the patient. Do we have a marker? Point. So this one, I'll just stop the clip at the time of where the tumor. This is the area where the tumor, there is a suspicion of the tumor, and there was the bulky pancreas. That means there was still the recent pancreatitis. But as the USFNA showed atypical cells, we decided to go for a laparoscopic distal pancreatectomy with splenectomy because of the suspicion of malignancy. So these are all standard steps. We usually do the first neck transection, and one of the first important steps is to safeguard the hepatic artery, because if there is a catastrophe while dissecting, always you should stay left of the celiac axis so that you will not injure the hepatic artery accidentally. So hepatic artery is looped above the border of the pancreas, and then the superior, after the transection of the neck of the pancreas and the splenic vein, we go for the superior dissection. Because this was a difficult case, there was no plane after acute pancreatitis. It was very difficult to delineate the splenic artery. So this is the area where the dissection is difficult. This is the most important point, that we should safeguard the hepatic artery first, dissect the hepatic artery as much as possible, and then stay away from it. So this is division of the vessels to the pancreas, and then the left gastric artery is safeguarded. Dissect on the left gastric artery. There is relatively good plane in that area, and although we could not see exactly where the splenic vessels were, splenic artery was originating, that splenic artery was clipped, and it can be divided close to the pancreas and can be managed with a bipolar device. The second problem in this patient was adhesions of the stomach to the superior border of the pancreas, and stomach was opened, and there was significant bleeding from the gastric vein. So this is the area where the stomach was adherent, and stomach had to be dissected off the pancreatic superior border, and there was significant bleeding from the probably posterior gastric, or it may be veins from the lesser, near the lesser curvature. So this was also clipped. The technical difficulty is that we are sometimes very difficult to identify this. So we need to dissect out and keep the organs or vessels which we need to preserve. That is the most important point. Once you reach the splenic hilum from medial to lateral, then the dissection is quite easy, because there are no major structures to injure in that area. So this is the after the dissection. I am not showing the entire video clip. So we have safeguarded the hepatic artery and the left gastric artery, and the splenic artery is clipped and divided. So this is one of the difficulties which we faced when we dealt with acute pancreatitis in a pancreatic tumor. Again, the histopathology came as a 2 centimeter pancreatic adenocarcinoma with no lymph node metastasis. So this is another man who had no other comorbidities, 58-year-old man. He had 2 episodes of vague abdominal pain. He had a sleeve gastrectomy 12 years back. He was evaluated with CT scan and endoscopy. This CT again found a mass in the body of the pancreas. Again, the technical details of pancreatic neck dissection is the same. It is usually easy if the tumor is not close to the sphenoportal axis, easy to get this plane on the anterior surface of the portal vein, and the pancreas neck is looped. Here again, I would make sure that the hepatic artery is safeguarded at this level. You can keep the dissection with blunt dissection with either a suction or a gauze piece. Here the hepatic artery is being dissected and looped to safeguard it, and then the pancreatic neck transection is done using a purple stapler. The transection takes at least 2-3 minutes. It's a very slow transection. We usually use not an automated, that is not the Signia, but we use the mechanical manual stapling device. After the neck transection, the splenic vein is clipped and divided. If the tumor is not close to this area, it is not very difficult. The splenic vein can be transected either with a vascular stapler or using clips. So this patient had a distorted anatomy because of the, probably because of the previous sleeve gastrectomy and torsion of the stomach sleeve. This is the dissection between the splenic artery and the left gastric artery. So we have already clipped the splenic artery, and we are searching for the splenic artery, and suddenly there is a bleed from that area, although we were not dissecting in anywhere near the splenic artery. Tried to clip. Again, there is no, you cannot stop me now because it is bleeding. So we try to suture. We have tried to suture with proline as expected, it is not stopping. So try to catch with the left hand, tried multiple clips in that region, but ultimately somehow we could get a suture in that. Again, the temperature in the theater had gone up above 100 degrees. After around 20 to 25 minutes of struggle, somehow the left hand dissector caught hold of the bleeder, and that bleeder could be clipped. So I wanted to highlight this because we should expect any problem. You can see the strength of the clip in this, how strongly you took out the pulp of that artery because you struggled for 27 minutes. So then the splenic artery was controlled, and then the dissection was not very difficult. This is the end of the battle after probably 3 hours of surgery. You can see that what the splenic artery, what we thought it was the splenic artery which was clipped, was actually the celiac trunk. And although it was lucky that the hepatic artery was spared, and this is the aorta. So this was a laparoscopic Appleby procedure, although it was accidental. This patient had, I just wanted to highlight the difficulty which can be encountered if we are not expecting this. If you are seeing this CT scan, we went back and checked the CT scan, you can see that the celiac axis is distorted and the splenic vessel is originating, the hepatic artery is going towards the left. So this was the area where we were dissecting very close to the celiac artery, thinking that the hepatic artery is the splenic artery. So sometimes when you face these problems, don't ring the bell, keep on dissecting and do a safe surgery. Thank you very much for watching.